Thank you, Ross. Sometimes in clearing things up, you can actually muddy things out a bit. Good morning, everybody. Good to be back in front of everybody trying to make sense of a topic which is really quite sensible. Posterior malleolar fracture reduction, when to fix, was what I was tasked with. I'll get there eventually, trust me. But going through the goals of surgical treatment, it becomes pretty clear. All displaced ankle fractures present a challenge to the ankle mortise, and stability is the name of the game. Posterior malleolus forms part of that socket. I could tell you from some pretty brutal experience over the years trying to recreate ankle fractures in the lab. I'm an automotive engineer. We tried for years to recreate isolated lateral malleolar fractures, medial malleolar fractures, posterior fractures. And the only thing we were able to recreate really was a pilon fracture with axial load, with rotation, different positions of the foot. So the posterior malleolus, how it fractures or why it fractures, remains a bit of a mechanical mystery, but its role in the stability and knowing the ligaments that attach to it, observing on the x-ray the displacement, and as with all fractures about the ankle, you want to recognize them early, get to treat them early, and anatomic reduction and stable fixation is the goal. So the confounding elements with the posterior malleolar fracture is what else is broken and what's the degree of instability of the ankle. So when you see something like this, you don't see a displaced posterior malleolar fracture, but there is one. And the question then becomes, or the challenge is, do you ignore it because it's non-displaced and stable in this position, but the rest of the ankle is not stable, or do you fixate it in situ? And so you look at the usual suspects and make sure you have a stable socket. The axilla, the medial clear space, lengthen the fibula, all those need to be addressed in the unstable ankle fracture. And what you want to do with the posterior malleolus is return it to a near anatomic state and see that it's well fixated if you're going to fixate it. And the displacement is evident on a lateral x-ray. There's no need in most cases to do a stress test. And if you were to stress it, you would like to know the AP stability of the talus and the mortise regarding the posterior malleolus. And your surgical approach, if you're going to be on the lateral fibula, you can come posterior and get to the posterior ankle socket. That's a reasonable exposure. If you can get a closed reduction and you're happy with it anatomically, you then can do fixation from the front with percutaneous guided screws, or you can continue with a posterior approach, particularly with a large enough fragment that you would like to buttress it and put a vertical plate with screws proximal to the fracture. And there are some fractures that just, as I showed in the radiograph before, they really don't need reduction, but you have to suspect that they will be unstable, even with a fixated medial malleolus, reduced talus, and out to length and happy fibula. So the timing is one of the elements that's really not well described in any of the literature I came across. But certainly, if you let too many weeks go by, it's difficult to get a reduction of a displaced posterior malleolar fracture. So you want to get it on the schedule fairly early if you know that you're going to have to reduce a large fragment. And the size of the fragment, which was a big issue when I was coming along in training, and the number 25% of the joint surface always seemed to pop up, and it was hard to find literature to support that. And we certainly couldn't support that with the pilon fractures that we created in the lab. But you certainly want to remain skeptical that a small or a large posterior malleolar fragment can be half-heartedly reduced and half-heartedly fixated. It's really part of the stability of the ankle socket. So you can, in most instances, reduce and fixate the posterior malleolar fracture if you're going to be operating on that ankle. So the short answer to the question I was posed, when to fixate, you really won't be criticized, and there's really no harm in fixating all of them if you're going to be operating on an unstable ankle. If it's a stable fracture throughout the mortise and minimal displacement, you can certainly go for non-surgical treatment and observe how this patient does. Weight bearing is not going to influence the posterior malleolus, either in its reduction or its stable fixation. Motion throughout the ankle, particularly loading the forefoot, may stress the posterior malleolus. So if you're going to have weight bearing, it should be with a neutral foot and a vertical load. Try not to eccentrically load the ankle. And my friends down the road in Winston-Salem routinely inject the gastroc with Botox for the treatment of pilon fractures, posterior malleolar fractures. That's so you don't lose dorsiflexion when you rehab the ankle. They also do that for Achilles tendon ruptures, by the way. Interesting, they haven't published it yet, but I know those folks well, and I know they do that on a routine basis. Something to think about. So here's a stable ankle, and if there's a posterior malleolar fracture, it's going to show up with the displacement there posteriorly, and you will have the question of, should I fix or shouldn't I fix? So I think that fixing the ankle also gives you the ability to look for things that could be trouble down the road. Loose body, third body wear on the ankle is always a problem with displaced fractures. The damage done to the cartilage is something beyond our current ability to modulate with any biologic treatment, but that may change over the future. And certainly the leading cause for ankle arthritis is idiopathic, and close behind that is post-traumatic. And the post-traumatics tend to be the ones that had initial displacement and instability. So is there an optimum time and an optimum construct? No, it's pretty much in the eye of the beholder, but as with most other fracture work around joints, you want to get an anatomic reduction of that fragment. You want to reduce loose bodies from the ankle that are originating from that fracture. And you want to buttress the larger fractures because that certainly adds to mechanical stability. And here you have someone who left the operating room in a less than ideal situation, and there was an unrecognized instability due to a fairly significant posterior malleolar fracture. So anatomic reduction doesn't guarantee a lifetime of ankle function, but given what we know how to do to avoid problems down the future, fixating, yes, no, I think err on the side of yes, and be sure that it's anatomically reduced. So in summary, the reduction of the posterior malleolus is the primary goal, and achieving stable fixation. Timing, not critical, but earlier is better than middling or late. And you can choose your surgical approaches based upon what else is going on around the posterior malleolus. So you want to restore lateral length, you want to get the axilla reduced, and you don't want to leave behind any significant cartilage or bone fragments in the posterior joint. Choice of hardware, I think, is a dealer's choice. The mechanical studies on cadavers, of which I'm guilty of having created some of that literature, really doesn't show a clinical significance when followed up. So fix them, and I think you'll sleep better at night.